Hello and welcome to today's webinar, Making Sense of Cancer Screening, hosted by the American Association for Cancer Research and Cancer Today, a great magazine focused on cancer. I'm Bill Nelson, the editor-in-chief of Cancer Today and director of the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. I'm both a physician and a scientist, and I'm a member of the American Association for Cancer Research, also called the AACR, which is the world's first and largest cancer research organization, bringing together the greatest minds in cancer research throughout the country and the world in the quest to cure and prevent cancer. Cancer Today is AACR's signature magazine for patients, survivors, and caregivers. And there's a lot of information out there about cancer screening. Our goal today is to shed some light on screening guidelines and provide you with options and considerations to help you make informed decisions, and also give you a sense for what the future holds for cancer screening and early detection. Two items to note. Our webinar is designed to be educational. Nothing in this webinar is intended or should be construed as formal medical advice of any kind. Also, the opinions of our presenters are their own and not necessarily reflecting those of the AACR per se. Now I'll share with you today's format for this 60-minute webinar. You'll first hear from Dr. Ernest Hawk about colorectal cancer screening. Then I'll talk about prostate cancer screening. And then I'll introduce you to Elaine Shatner, who will discuss breast cancer screening. After each presentation, there will be a brief time for question and answer. You can write in your questions on the webinar dashboard, and we'll have time to answer at least a few of them. And now I'd like to introduce Dr. Hawk to discuss colorectal cancer screening. Dr. Hawk is on the Cancer Today Editorial Advisory Board and is the Vice President and Division Head for Cancer Prevention and Population Sciences at the MD Anderson Cancer Center in Houston, Texas. Dr. Hawk.
Good morning. My name's Ernie Hawk. I work at the University of Texas MD Anderson Cancer Center. I have the pleasure of speaking with you today about screening for colorectal cancer. The process of cancer development in every organ, but particularly in the colorectal, is a protracted process. When I was trained as an oncologist, I was taught to pay attention to people presenting with cancer. And back then, some 20 years ago, we didn't realize that cancers follow this protracted process of development. But in the last 20 years, we've come to this realization. So this slide shows moving from a normal colorectal mucosa here on the left to advanced cancer here depicted on the right goes through a process of development that can be identified through endoscopy, taking a look at the lining of the colon. And what this is pointing out is that along the way there are these precancerous polyps or adenomas that develop. We used to think of these as benign and utterly distinct from cancer, but now we realize that they are an intermediate stage of the cancer's development. And so this is a protracted process taking anywhere from 5 to as many as 35 years in most individuals. And they're not independent stages, rather this is a progressive process. And the progression of that process is influenced by genes, the genes that you inherited from your parents, as well as lifestyle choices that you make every day, as well as the passage of time or aging. So I want the next couple of slides go into details about how we can address the problem of colon cancer before it develops by paying attention to these influences. So first up, genes. Some colorectal cancers are inherited, and that's because of the inheritance of dominant mutations or changes in the genetic code that strongly predispose to the development of both polyps as well as colon cancer. Fortunately, those conditions are rather rare, but they're important to identify because they influence all aspects of management of those individuals from screening through diagnosis and treatment. On the other hand, most colorectal cancers that occur in the general population have a heritable component. That is, your inheritance, you may inherit tendencies, but not strong influences. And in those cases, many times we've not yet identified the specific genes that place you at increased risk. But the important message is that a positive family history for either colorectal polyps or cancer in a so-called first-degree relative, mom, dad, brothers, sisters, children, places that individual at increased risk for cancer. And that increased risk means that they should begin screening at an earlier age, screened more often than someone at average risk, and many times screened using more specific and sensitive technologies like colonoscopy, as opposed to some of the other screening tests we'll talk about. So your genetic history, that family history of polyps and cancers, has a lot to do with subsequent cancer risk. The other point I want to highlight is that there's a lot that we can do through choices in our lifestyle that influence colon cancer risk. It's estimated right now that in the United States, nearly half of colorectal cancers could be prevented by adopting and maintaining across the lifespan a healthy lifestyle. What does that mean? Well, it means avoiding tobacco and alcohol, both direct personal use as well as exposure. Secondly, maintaining a healthy weight across your entire lifespan. Being physically active, that's at least 30 minutes of vigorous or moderate level exercise, walking, jogging, those sorts of swimming, those sorts of activities every day. Fourth, reducing or eliminating consumption of red and processed meats. This is important because some of those processes, as well as red meats, contain chemicals that can harm the lining of the intestine and increase risk for colon cancer. So again, restricting consumption of those is recommended. And then finally, increasing your consumption of fruits and vegetables, particularly those containing high amounts of fiber, have been associated with reductions in colon cancer. So a lot that you can do to try to decrease the development of this disease right from its inception. But we're here mainly to talk about colon cancer screening. And this slide summarizes the current recommendations in a straightforward manner. So for average risk individuals, these are folks without that family history of polyps or cancer, it's recommended that adults between the ages of 50 and 75 undergo screening that starts at age 50 and continues on a periodic basis through that age of 75. That's got the highest level of evidence and therefore receives a grade A recommendation from the U.S. Preventive Services Task Force as well as other leading professional bodies. Older than that, ages 76 to 85, it's recommended this be a very individualized decision, and it's based upon your overall health, your prior screening history and what might have been found in those processes, and your competing causes of morbidity or mortality. You know, what is the context in which colon screening may or may not make sense on an individual level? The good news is that by following these recommendations, it's estimated that we can reduce the development and the death due to colon cancer by at least 30%. Now I'd like to cover some of the options that are available, and there are many. That's good news, but also can be somewhat confusing. So I'm going to try to break down the various screening options available that are currently FDA approved and recommended. They fall into two broad categories. First of all, those that can detect cancers earlier, and then secondly, a group of tests that can both detect cancer early, which is terribly important, but also, even by finding precancerous polyps, adenomas, prevent the onset of colon cancer. And they range from stool-based tests, where these are tests that are done at home, they're non-invasive, you just take a bit of stool, put it on a card typically, and then mail that card off for evaluation. Some of these have dietary restrictions. They typically look for either blood in the stool or for molecular defects characteristic of cancer that can now be identified in stool. There's one that's commercialized and promoted on television, for example. So there are various types of these. The fact is, though, that they've been proven to reduce colon cancer mortality. The challenge is that they have a high false positive rate. That is, they can sometimes suggest colon cancer, but actually be due to something other than colon cancer, so requiring a need for follow-up evaluations. Second, there's a class of blood tests that have been developed, and there are many more on the horizon. This first one that's currently FDA approved is done in a doctor's office by a simple blood draw. It detects something called methylated Sept9 DNA, and how often that should be repeated is the real question, unknown at the moment. those stool-based tests need to be done annually or every other year in order to demonstrate that reduction of mortality. Third option or class of options is colonoscopy. This is where a physician would pass a lighted tube into your colon and go all the way throughout the entire colon, examining the lining. This is typically done in a hospital or endoscopy center, so it requires a process of establishing an appointment. It is somewhat invasive because, again, this tube will be inserted through your rectum into the colon for the physician to take a look at it. It therefore requires an extensive bowel prep to rid your colon of waste, and it also requires sedation. So typically you'll need a family member to take you to, or a friend to take you to and from the endoscopy center. The fact is, though, this takes a look at the entire lining of the colon and can detect both those polyps as well as colon cancer, so a very effective strategy. Flexible sigmoidoscopy is basically the same thing, but with a shorter tube, and it doesn't require sedation. Typically just perhaps a enema to clear the distal part of the last part of the colon. And so this is, again, an evidence-based test. It needs to be done every 5 years, colonoscopy every 10 years in order to see those benefits in terms of cancer prevention and reductions in cancer death. And then finally, another relatively new technology is an X-ray exam. This is where you lie on a table and go through a CT scanner, and it takes pictures, cross-sectional pictures of your colon, which are subsequently reconstructed. These are done at an imaging center or hospital. They are semi-invasive because the physician typically needs to insert some air into your colon to distend it so good pictures can be taken. It requires a bowel preparation, but it doesn't require sedation, and it typically takes perhaps an hour in duration for the entire procedure, and again takes a look at the entire colon. This is required every 5 years. Now, talking a little, the important thing is any of these tests, if it identifies something so-called screen positive, important to follow up subsequently with colonoscopy for diagnosis and treatment. A bit more about these various options in terms of the practical issues that concern most patients, and that is the outcomes, complications, price, and insurance coverage. Stool-based tests, again, have that 30% mortality reduction, so definitely recommended. They have some complications, but really related to the downstream colonoscopy for screen-positive individuals. Estimated price, these are cheap, anywhere from $500 to $500. Again, need to be done, though, every year or 2 years, and their costs are covered by Medicare and most other insurers. The blood-based test has a little less sensitivity or ability to detect colon cancer when it's there, but nevertheless is evidence-based and recommended. All it requires is a blood draw, so no serious complications. Prices are unknown with regard to this test. It's dependent on the individual market, and they're not currently covered by Medicare. Colonoscopy has a very substantial mortality reduction, anywhere between 70 to 85%. It is associated with more serious complications, a greater frequency, and sometimes types. However, it's deemed to be a safe procedure. You can see on the order of 10 to 15 serious complications per 1,000, or perhaps 1%. The estimated price is substantial, $1,500 to as much as $1,700, and it's covered by Medicare at no cost. Flexible sigmoidoscopy, a bit less expensive here, only $850, again covered by Medicare at no cost. And then finally, CT colonography, that CT scan evaluation, very good sensitivity and specificity. The challenges there, low dose radiation exposure, as well as it can find other things in your abdomen that were not anticipated, leading to further testing. Estimated price anywhere between $500 to perhaps $700, not currently covered by Medicare or most other insurers. So those are the practical issues. I want to leave you with just a couple of other concepts, and that is, first of all, we've talked about the importance of that initial risk assessment. Does your mom, dad, brothers, sisters, children have polyps or cancer? That's the first most important aspect of colon cancer screening. Thereafter, going through the test at the recommended intervals is really important. Downstream of that, anyone who shows up with a screen positive needs to follow up and undergo diagnostic colonoscopy to evaluate whether that's a polyp, a cancer, and what should be done about it, and then, of course, connecting that diagnosis to treatment. So this should be viewed as a process rather than a simple test. The good news is that colon cancer is highly preventable in 2017. We are able to prevent that by adhering to the published recommendations for cancer prevention. As I mentioned, they include lifestyle choices and knowing your family history. Did your mom, dad, brother, sister, children have colon polyps or cancer before the age of 50? And if so, you need to let your physician know that so that they can make the appropriate screening recommendations. Next step is to undergo one of the recommended screening processes. Again, there's a wide choice of options and benefits and risk costs to each of them. Finally, important to share the results with your family and to participate in research studies wherever possible so that we have better options tomorrow than we have today. But this is a highly preventable cancer through both lifestyle choices as well as screening. Thanks very much for your attention. I'll now turn it back to Bill.
Thank you, Dr. Hawk. And before we turn to a couple of questions, I just wanted to share the results of the poll that was done at the beginning of this. It turns out, of those of you in attendance today, 11% are cancer survivors, 2% are in the midst of cancer treatment, 37% have loved ones, family members with cancer, 72% consider themselves an advocate for patient health, which is a good thing, and 41% are interested in maintaining their own health. So as we turn to questions, the first one that's come in, Dr. Hawk, is what's more important when considering planning a screening strategy for colorectal cancer, whether colorectal cancer seems to run in your family, inherited factors, or things about your lifestyle that you mentioned which might foster colorectal cancer development? Which is more important?
Well, both are very important. I would say for most Americans, it's the latter. It's the lifestyle choices that are believed to have the greater impact. Again, up to a half of colon cancer right now is estimated to be associated with those factors. So maintaining a proper diet, physical activity, avoiding smoking, alcohol, doing all of that minimizes everyone's chance of colon cancer development. So that's probably the most important single feature.
So there's a related question that's popped up, which is an interesting one, which if someone's father, let's say, or a father, has had colorectal cancer diagnosed at age 72 and does not have a known strong inherited risk tendency to colorectal cancer in the family, should the children still start their screening at age 50, or can they wait a little bit to an older age?
Everyone should begin screening at least at age 50 by any of the methods that I described. So that's the first most important message. If you have a first-degree relative, father in this case, who developed colon cancer at an advanced stage, that increases your risk, but not dramatically so. And so most gastroenterologists, primary care physicians would probably recommend that individual to be roughly at average risk and begin at 50. If that colon cancer occurred at a younger age, prior to 50 in particular, is when we would designate a very high risk and then need to start earlier and by more dramatic measures.
Another thoughtful question that's come in is if things like eating processed red meats and these kind of things augments colorectal cancer risk, should someone who believes that they've overindulged in those kind of dietary tendencies, should they start their screening at a younger age than age 50?
Yeah, there's no evidence currently to be able to make that assessment. The fact is that most of the American population for whom these recommendations were drafted have consumed meats and done other bad things that contribute to age-related lifetime risk of colon cancer. And so I would say those sorts of individual decisions are baked into the recommendations to begin screening at 50.
Well, super. That looks like that's it for the questions. And it's a wonderful discussion. Thank you very much, Dr. Hawk. So next we're going to move on to an area that I spend my time thinking about, which is prostate cancer. And we're going to dive into screening and early detection for prostate cancer. First, I have a number of outside activities for which I get paid. At least one of these has to do with building new tools for prostate cancer screening and early detection. So you should measure anything I say about these types of new products with that in mind. So prostate cancer screening has become somewhat controversial. If you look at the U.S. Preventive Services Task Force, it's given prostate cancer screening a grade D, which is not a very good grade. Their logic was that they believe that the reduction in prostate cancer mortality out to 10 to 14 years is very small, even for men that have been screened at the optimal age of what seemed to be 69 years. They believe that screening has not led to a dramatic reduction in all-cause mortality, and they believe that some of the harms associated with the treatment that is launched by screening for prostate cancer are common. They often persist throughout life after the treatment and include a small but real risk for premature death. And they believe that more screening will lead to more harms and not enough life-saving to merit use of PSA screening generally. So they believe that the benefits of screening don't outweigh the harms. Prostate cancer is a disease we should think a lot about screening because it's incredibly common. It's the most commonly diagnosed life-threatening cancer in men, 26,000 deaths in 2016. The problem is that small prostate cancers are present in this country in at least 30% of men between the ages of 30 and 40. That's something really to put your mind around. And 2/3 of men between the ages of 60 and 70. So most men develop small cancers in their prostate. The lifetime risk of prostate cancer diagnosis is only about 1 in 8, and the lifetime risk of dying of prostate cancer is only about 1 in 37. So already you can see one of the challenges to screening for the disease, and that is if we detect the disease, most men will die with it and not of it. So clearly what we'd like to do is use screening to prevent men from dying of prostate cancer, but we run the risk of finding prostate cancers that are not life-threatening. If you look at many of the other organizations that have looked at these data and have screening recommendations or guidelines, including the American Cancer Society, the American Society of Clinical Oncology, the American Urological Association, most of them recommend screening, but they recommend screening after a very significant discussion of patient and family members with healthcare providers that adequately considers the potential risks and benefits. So if you look in general, most people think that PSA-based screening should begin at age 50 to 55 years, earlier perhaps in African American men who are at increased risk for suffering with prostate cancer and life-threatening prostate cancer. Perhaps should start before age 50 in men who have a strong family history in which their father or their uncle may have developed prostate cancer at a young age. And that, again, all men at risk for prostate cancer should participate in shared decision-making with a thorough discussion of potential risks and benefits. So what is PSA, the basis of screening? PSA is an enzyme protein that normally appears in the ejaculate for sexual reproduction. But in the case of prostate diseases, particularly prostate cancer, the benign enlargement of the prostate, and prostate inflammation called prostatitis, itis means inflammation, the PSA can backflow into the blood circulation. So the detection of PSA in the bloodstream is an indication of prostate cancer, benign prostate cancer enlargement, or inflammation of the prostate or prostatitis. The reason PSA is a very interesting tool for prostate cancer comes from studies like this, which I've captured on a graph for you. This was a study of aging in men, where men appeared at the National Institute of Aging for a variety of data to be collected, you know, their weight, their height, blood tests for various things, and they collected blood and they archived it for many years. This was in the era before PSA was used for screening for prostate cancer, and yet in this study, as they watched men age over a number of years, they found that some men died of prostate cancer. That's that wave of graph at the top, dead of prostate cancer. They found some men were diagnosed with prostate cancer but were treated for cure of the disease. So they never died from prostate cancer, but they were diagnosed with the disease. And then some men never got prostate cancer they could detect. If you look at time zero, which on the bottom axis of the graph we call the x-axis, time zero, and you go back and say, How many years before that did the PSA start to rise? What you can see, if men died of prostate cancer, as much as 15 to 20 years before they died of the disease, the PSA started to inexorably rise. In fact, the shape of that curve, it arose exponentially, 2 begets 4, 4 begets 8, that kind of a rate, which tantalized people, saying, look, there is a long period of time before a man diagnoses with prostate cancer that you might be able to use PSA to detect that cancer at a more curable stage. And this is why PSA has gotten into this use. And the randomized trials of PSA screening, the best one being a trial done in Europe, where they randomized men to get PSA testing every 4 years or not to be tested. If you look at the results of that trial, they definitely suggest that if you detect prostate cancer early by PSA screening, you can detect it at a more curable stage and you can improve outcomes from prostate cancer. So if you look at the results, a 40% reduction in the propensity for prostate cancer to spread throughout the body, we call metastasis or metastasizing, a 20% reduction in death from prostate cancer by 13 years. But here's the challenge. 781 men needed to be screened. 27 men needed to be diagnosed and treated for prostate cancer to save one life, to prevent one prostate cancer death. Again, many more men with prostate cancer were dying with the disease than of it, and so the treatment was only preventing a small number of prostate cancer deaths for the total number of men diagnosed and treated. The cost effectiveness at a societal stage was reasonable, $73,000 per quality adjusted life year gain. And even in this study, which suggests that prostate cancer screening is effective, it did not appear to be very effective as men got older. As men got to be in their early, mid, and late 60s and 70s, the screening was less effective because they detected more non-life-threatening prostate cancer, and it started to outweigh the life-threatening prostate cancer they detected. Here's another graph to look at this kind of notion. If you look at African Americans and Caucasian Americans in age buckets, 20 to 29, 30 to 39, as you can see over the bottom axis, and you look on the height of these bars is the percentage of these men that are found to have prostate cancer at autopsy, you can see it's stunning. African Americans and Caucasian Americans have a lot of prostate cancer, much more than we're ever going to diagnose, much more than is ever going to threaten life. You see on this graph that Asian men who live their life in rural Asia don't get prostate cancer at all. That makes many of us think that there's something about the environment in the Western world that accelerates prostate cancer development, or something in rural Asia that attenuates it, because Asian immigrants to North America typically have a risk of developing prostate cancer that resembles that of Caucasians. Most of us believe this is a wonderful opportunity to prevent prostate cancer if we could ever figure out the reason for that difference. But here's the other challenge, is it's very hard to use PSA as a single cutoff value. Most screening studies use a PSA of 3 nanograms per milliliter, 4 nanograms per milliliter as a cutoff value. But here's a study in which men with a PSA lower than that were subjected to prostate biopsy. As you can see on the left side of this table, PSA between 0 and 1, 1 and 2, 2 and 3, and 3 and 4, you can see that as many as 25 to 30% of men with a quote-unquote normal or not worrisome PSA had prostate cancer. Many of these prostate cancers were of the lower grade, non-life-threatening sort of style. And so many people, when they use PSA, are more interested in how the PSA rises, remember that graph that I showed you before, and not so much in what the cutoff value is in terms of being worried about the presence of a prostate cancer. One of the challenges, which I believe is going to get better in the next few years, is the way we diagnose prostate cancer in a man that has a suspicious prostate-specific antigen, a suspicious rectal examination, or both. And that is, we do templated biopsies using ultrasound to find where the prostate is, but we don't aim those biopsy needles at a particular abnormality in the ultrasound. Instead, we do at least 12 biopsy cores, 6 on each side of the prostate, attempting to sample the prostate in such a way that if we miss something, it can't have been very big. And so you can imagine in a prostate that has a number of small tumors in it, like is shown here in an artist's conception, if we put a needle biopsy like the one on the left, into the cancer, we detect it, and that person's been diagnosed with prostate cancer. If you look on the one on the right, there may be cancers around, but if we didn't steer the needle and hit them, then we'll tell this man that he doesn't have prostate cancer, even though he does. The suspicion is that among men with a negative biopsy, in other words, they didn't find cancer in any of the 12 cores, as much as 20 to 25% of them may have cancer the next time they get biopsied. So this is decidedly an imperfect strategy. The next slide, you can see there are some products, and this is one that I contributed to, so I'm not going to hawk this in any way. It's been approved by the FDA for use in trying to figure out who needs another biopsy, who had a negative biopsy, and if they grind up that tissue, DNA from prostate cancer, it's like if you can find DNA in a hair follicle at the crime scene, can you find DNA related to prostate cancer in biopsies in urine and blood and the like? This is looking for it in a biopsy that was otherwise negative. If it's detected, the chance for a man to have prostate cancer on a second set of biopsies is high. If it's not detected, the so-called negative predictive value, the chance for him to have cancer on a subsequent biopsy is pretty low, and you can reassure that man he doesn't need another biopsy. What's the future for this? There's a lot of people who work in the AACR, come to the AACR prostate cancer meetings and the annual meeting, trying to develop things that are better than PSA, proteins, DNA, RNA that might appear in the circulation, appear in the urine, to have new blood tests that are much more specific for prostate cancer, but also more specific for prostate cancer that's life-threatening. Can we recraft screening to detect life-threatening prostate cancer at a time when it can be treated for cure? That's obviously the hope. But even now, PSA screening is effective, and so this is the challenge that we have in using screening guidelines. If you look at prostate cancer mortality, it has fallen since we deployed PSA screening. The mortality rates are much lower now than they were in 1995 before prostate cancer screening. It's pretty hard to come to any conclusion other than screening has driven this decrease in prostate cancer mortality. If you look at areas that have high rates of screening, they're the areas with lower prostate cancer mortality. And as we've mentioned, 2 of 3 randomized trials have shown an improvement in prostate cancer outcomes with screening. I think, and many of us think currently, that the antidote to the over-treatment problem, this is the idea that with PSA screening that we detect cancers that might not be life-threatening, is that we can calibrate prostate cancers that we detect by their grade. This is something that a pathologist who looks at the biopsies through a microscope can assign, and then the pathologist can say, this looks like low-grade prostate cancer, which is not so worrisome, not likely to spread throughout the body, not likely to threaten life, and that if we detect low-grade prostate cancer, that the current approach that many people are adopting is to use active surveillance, i.e., let's not use radiation therapy or surgery to aggressively treat that prostate cancer, which carries with it a risk of side effects and complications. Let's watch this prostate cancer carefully and see if at some time in the future we might need to use aggressive treatment, surgery, radiation therapy. But for many men, it looks like you can get away without this kind of treatment. And this may be the antidote to the overdiagnosis and overtreatment problem presented by PSA screening. And if you look at active surveillance regimens, usually they repeat PSA tests to see if the PSA is rising. They do digital rectal examinations. They'll do another biopsy usually to see if they've missed a high-grade prostate cancer. And imaging tests, particularly magnetic resonance imaging, is improving rapidly and is being more and more used in this setting. And I'll bet you will become more and more important to how we manage early stage prostate cancer. And then we use the aggressive treatment, surgery, radiation therapy, only for the men that need it. And I think with that in mind, that if we take PSA screening and its current controversies, what they really suggest is that a man should talk to his physician about the risks and benefits of PSA screening, about if a low-grade cancer that's not life-threatening is detected, the logic of using active surveillance to remain engaged with healthcare to ensure that only men with life-threatening prostate cancer get aggressive treatment and other men don't get so aggressively treated. So I think we're ready for questions. So one question is related to this notion that many of the recommendations for screening, colorectal cancer screening and prostate cancer screening, tend to start around age 50. One of the reasons for that, I would argue, is that if you look at overall cancer in the United States, 80% of all cancers are diagnosed above the age of 80, and 30%, I'm sorry, above the age of 60, and 30% of cancers are diagnosed above the age of 80. So in general, more cancers appear in people as they get older. And so screening men in their 50s, colorectal cancer screening and prostate cancer screening makes sense because that's when the disease appeared. There are certain populations of men in particular, and Ernie Hawk talked about a few of them, men with known syndromes that are prone to develop colorectal cancer at an earlier age when you would start screening earlier. Many people believe that African American men might be better starting screening at age 45 because their risk of dying of prostate cancer is about 1.7 times the risk of Caucasians. So I think that's one of the reasons that it's biased to above age 50. So another question was, is there any test for prostate cancer that doesn't depend on a blood test for PSA or the serum prostate-specific antigen level? There are an increasing collection of tests that sample other aspects of prostate cancer, acquired gene defects in the disease, acquired changes that cancers display that normal cells don't. Many of them have been tested and detected in the urine, some of them in the bloodstream, some of them in the tissues. And I would argue that those collection of new tests have just started. Some of them have just begun to get FDA approval, none of them approved for screening as of yet. In addition, there are all kinds of modified PSA assays that increase the predictive value of PSA to diagnose higher risk disease, the disease that's likely to threaten life. And so I think the good news is that these screening processes are improving, and I believe will improve a lot as some of these new molecular tests come along online. And I think maybe one more question. We're doing pretty well. See if I can find in this thing. They queue them up for me very nicely. Let's see this one. How can I figure out if prostate cancer screening will help me personally? Well, as I hinted, I think the best approach to that is to have a significant conversation with your physician about the risks and benefits of screening, this so-called shared decision-making. And some people just have a different attitude toward what they'd like to do in their health. They may be more concerned about overtreatment, or they may be more concerned about prostate cancer. If, for instance, a brother had had prostate cancer, became very sick, someone may be very concerned about prostate cancer and want to take maximum advantage of screening in an effort to reduce the chance that they might be threatened or life might be threatened by prostate cancer. If, on the other hand, they know 2 or 3 people who've had bad side effects from treatment, they may be someone who might not want to pursue a screening. So why don't we move on and talk about breast cancer screening. We're going to move on to Elaine Shatner, and Elaine is a breast cancer survivor, an advocate, medical commentator, and former cancer physician and scientist. And Elaine's going to walk us through some of the issues related to breast cancer screening. Elaine.
I'm Elaine Shatner. I'll be speaking on breast cancer screening. The most important word on the slide, and I think in my talk, is choice. And the decision to get screened for breast cancer should be informed by current information. I have no financial disclosures. Okay. I like data, so we'll start here. At center is a graph which shows that deaths from breast cancer have declined dramatically. This shows data in the United States from 1975 to 2013. And basically deaths per 100,000 US women have declined by over a third, by 36% in that time interval. And that's a steep decline. You can see most of that drop has occurred since 1990. But it's on the wrong slide. Which one? 3. And so this decline in breast cancer deaths is really clear. And the question at the heart of the screening debate is if the decline in breast cancer deaths since 1990 is due to early detection, due to better treatment, or both. Slide 4. So I like to ask questions, and I think the most important one here is if you want to get screened for breast cancer. Not everyone does. You have to consider your risk. It's worth stating that men can and do get breast cancer, but their risk is very small, and so screening is not recommended. For women, the risk factors include getting older, having a family history of breast cancer, inheriting a BRCA mutation or other genetic disposition, or a personal history of another cancer, or a prior breast cancer. Those all put you at greater risk. How to get screened is not a trivial question. There are different ways to do it. Mammography is the gold standard, but there are other ways which we'll discuss. At what age to begin? Age 40, age 45, age 50, or not at all? And is there an age to stop screening? For some physicians think that at a certain point, if a woman is likely to die of something else, such as heart disease, screening becomes pointless. And then how often to be screened? That's a big deal. A number of groups advise screening every other year. The advantage of every other year screening is that you can half the dose of radiation to which a woman is exposed through mammography. The risk is that you may miss a tumor that's fast growing. I think the hardest question is why to get screened or why not. And I ask listeners to think about that after this discussion. I know people who are at high risk for breast cancer and who basically put off screening because they're afraid. They don't want to deal with it. They don't have time for breast cancer, that sort of thing. Some people are more comfortable with uncertainty or take a certain fatalistic attitude about their health. Others want more information and some control over their breast health. Next slide, please. What is breast cancer screening? First off, it's not just mammography, which is what you hear about and so many of the studies consider. Screening is a way to detect breast cancer before it causes symptoms or serious health problems. Ideally, it's a way of finding cancer before it spreads. It is not preventive, it is not foolproof. Physical examination is the oldest way of breast cancer screening. And doctors and nurses used to be trained in this. We used to teach patients and women in general just to examine their own breasts. It's fallen out of favor. There are no data to support physical exams for screening, and yet many doctors do recommend that women examine themselves once each month, and certainly if they do feel a lump, that they come in for evaluation. Mammography is at the center of breast cancer screening. Really, it's an X-ray of the breast, typically in 2 dimensions. Since around 2005, most practices in the U.S. have converted from X-ray film storage of the mammographic images to digital mammography. And in digital mammography, the images are stored electronically. Tomosynthesis is basically a fancy name for 3D mammography, which is becoming increasingly popular and at this point is basically standard in many practices and in academic centers. I think of 3D mammography as like a mini CAT scan of the breast. Radiologists have published extensively on it. They say that the callback rate is lower, and so that's an advantage. A disadvantage is that there's a slightly increased amount of radiation to which women are exposed in this procedure. Supplemental imaging to keep in mind include MRI, that's mainly reserved for high-risk women, and breast ultrasound, which has been shown to be useful in evaluating dense breasts. So dense breast is a benign condition when the breasts are more glandular than usual. Dense breasts are more common in younger women and in perimenopausal women. The problem for mammography with dense breasts is that the glandular tissue tends to obscure or block the appearance of cancer in the breast. What's shown here is a mammogram by the side, and you see a lot of sort of white stuff, and that's glandular tissue which obscures cancer. With sound wave test and ultrasound, radiologists who are trained in this can see a cancer which typically appears dark against the lighter background of glandular breasts. And so some radiologists like this method for discerning breast cancer and picking it up in women who have dense breasts. Some women like it too because there's no radiation. It's worth stating that there is no blood test to detect breast cancer. Next slide, please. Okay, so the recommendations. So despite all the controversy about breast cancer screening, there's a lot of consensus here. Now this is for women at average risk. None of the major groups recommend routine screening of women who are under 40 years. For women between the ages of 50 and 75 years, they all say yes, including the U.S. Preventative Services Task Force. And the difference is in recommending it every 2 years or every year. But they all agree that most women, if they choose to get screened, should be screened, and that doctors should advise women to get screened. For women between the ages of 40 and 49, you see that there's an emphasis on individual decision, discussion, words like that. The American Cancer Society recommends that all women be screened annually beginning at age 45, and that the opportunity be offered starting at age 40. The other groups vary in their specific recommendations for women here. For women above the age of 75 years, there are no data. The consensus is that if a woman is unlikely to live for another 10 years, it's probably not worth screening. Next slide, please. So this is an important slide on the risks of breast cancer screening. So first, you hear about false alarms, what statisticians call false positives. And that's when screening finds something that turns out not to be cancer. And that could be extra imaging. So women get called back, or it can cause extra imaging, typically a sonogram or an MRI, or more images on a mammogram, or biopsies. And that can add costs to the imaging and to screening. And it also can cause anxiety and occasionally complications such as bleeding or infection after a biopsy. Most false alarms are callbacks for extra imaging. The missed cases or false negatives are when screening misses a cancer. And you know, we've all heard horror stories of women who go for a mammogram and then 4 or 5 months later they find out they have cancer. That shouldn't happen. It's unfortunate. It's the reality of screening, which is imperfect. I tend to think that, and I am confident that these false negatives are happening less often than they were 10 years ago and certainly than 20 years ago due to progress in radiology. Overdiagnosis you hear a lot about, and it's a concept which is somewhat controversial. Overdiagnosis refers to finding an abnormality that is unlikely to cause harm. So examples include when you find a slow-growing tumor in an older woman or someone who is likely to die of something else before the tumor becomes a problem. It includes finding stage 0 or non-invasive tumors. You may have heard of ductal carcinoma in situ, DCIS, depicted here, that's a pathology image, and LCIS, lobular carcinoma in situ. Some people say these should not be called cancers. Research is needed and is ongoing to determine the best management of those early stage conditions. The point I would make about them is that overdiagnosis can be separated from overtreatment. They're not the same. So overtreatment is when doctors give too much therapy or patients take too much therapy. So that might be surgical, like a big operation for a small tumor. It could be medical overtreatment, like chemotherapy or too much chemotherapy for a slow-growing tumor. And it could be too much radiation. I think that education of doctors and patients is the way to avoid overtreatment so that people don't overreact to finding a low-grade condition. Next slide, please. Yeah, so why choose screening? All right, I think there are a lot of reasons, some unfortunate. The reality is that breast cancer is very common and it's lethal. It's a leading killer of women in the US in middle age. The median age of diagnosis of breast cancer is 61 years. So half of women who are affected are under age 61. It kills a plane load of people in the US every day on average, and most of 1 million people worldwide. So breast cancer is nothing to ignore. So one benefit is that screening reduces a woman's chances of dying of breast cancer, and it may prolong her survival. The second benefit, which I think is clearer, is that early detection permits a woman who has an early stage tumor to choose less treatment. If you wait till a tumor is stage 3 or 4, you may not be able to get a small surgery like a lumpectomy, and you may not be able to skip chemotherapy. If you find a tumor when it's small, you may be able to get away with observation or very minimal treatment. Benefit 3, avoid the harms and costs of delayed diagnosis. This is an under-discussed topic because what happens is if you wait with breast cancer till it's stage 3 or 4, it becomes much harder to treat and more costly to treat. Unfortunately, stage 4 metastatic breast cancer remains incurable. Treatment is lifelong. Next slide, please. So 3 things I like to keep in mind about breast cancer screening are these. First, read carefully. A lot of the published studies and even the information you may receive from a doctor rely on outcomes of very old mammograms. It's kind of shocking if you look closely at the literature, including studies published in 2014. Pathology tools have improved dramatically since 1990 and 2000, and even in the past 10 years. You may have heard that doctors can't tell if breast cancer is likely to cause harm or if it's fast-growing. That's not true. The fact is that with pathology tools now in everyday use, doctors can tell if a tumor is fast-growing. They can look at the molecular type of the tumor to see what kinds of treatments would be reasonable, and they can tell the subtype of breast cancer. So there's a lot of information that can be obtained, and if you do find an abnormality, so that treatment can be tailored to the aggressiveness or the lack of aggressiveness of a tumor. I would emphasize also that radiologists are not all the same. Some specialize in breast imaging and do that every day at work. Others, do also CAT scans of the head and X-rays of the hip. And it could be that radiologists who are trained in breast imaging and who have more experience in breast imaging are more likely to give more accurate readings on mammograms. Next slide, please. So if you do choose to get screened, I encourage you to get screened at an FDA-certified facility. If possible, have the screen done by a breast imaging specialist. If you get screened every other year, especially, I think it may be worth traveling for the procedure to go to a place where there's expertise. Stay informed. These are some of the sites that I recommend that provide information, and talk to your doctor and to other women in your community about their experiences, good and bad. Thank you for listening.
Well, thank you, Elaine. Before we get moving on some questions, first we have the result of a poll question. Did you know your family history of breast, prostate, and colorectal cancer? And 84% of you in attendance said you did. You had a good knowledge of it. 16% said you did not. We have another poll question that you can work on as we motor through the questions, and we'll watch that get loaded up, I'm sure. In a second. Yes, if you've been screened for any of these types of cancer, have you shared the results with your family? Yes or no? Go ahead and vote for this, and then we'll start taking on some of the questions for Dr. Shatner. So one of the ones that came up was related to symptoms and physical findings of breast cancer. This is obviously screening attempts to find breast cancer before these have emerged. And the question that the person asked is, other than a lump or swelling, are there other symptoms or findings that are especially worrisome? And if a woman detects those, should she then pursue screening in some way, or should she take a different approach to the management of her breast condition?
Sure. Shall I answer that now? Yeah. So screening usually refers to evaluating women who are without symptoms. So once you have something that's concerning you, it wouldn't be considered a screen. I recommend that any woman who has a concerning symptom visit her doctor and get checked. And if you have a lump in the breast at any age, including young women, I emphasize that you push to make sure that's evaluated thoroughly, because although screening is not recommended for younger women, breast cancer does occur in younger women, also in men who have breast lumps. So it's really important to get that checked out, and you may need to advocate for yourself to have that checked out fully.
Well, it's interesting that your answer to that question, one of our listeners asked a question about male breast cancer, wondering how often does it occur? Are there screening approaches? Can you further elaborate on male breast cancer? You mentioned it a bit.
Sure. Well, I think we're learning more about male breast cancer as the public and doctors become more aware of it, that it happens. And so I think the male breast cancer accounts for about 1 in 1,000 cases, or maybe fewer. That said, it does account for some deaths in the U.S., most of 1,000. And what's advised is that if a man notices a lump in his chest, that he get it checked out and biopsied. And doctors, he may need to say to his doctor, could this be breast cancer? Also, some genetic dispositions to breast cancer, such as BRCA mutations, particularly BRCA2, we know dispose to male breast cancer, and men with those mutations should be aware of their increased risk.
So there was another question that was an interesting one that was asked in a particular way, but there's two questions that follow on immediately from it. What the woman who asked a question related to, if a woman has had bilateral mastectomies and there is a concern for breast cancer recurrence, are any of these tools that are useful for screening useful in that setting to monitor for recurrence? And I would augment that to, there are women who've had nipple-sparing mastectomies as a prophylactic tool, but there is some duct tissue that remains. There are women who've had breast implants. When you look at the various scenarios where women have had their breast treated in some way, which of the screening tools still perform well? Which should they think about screening in a different way? You know what I'm getting at.
Yeah, so in a woman who has had bilateral mastectomy, let's say without nipple sparing, I don't think there's any role for the conventional screening methods. If there's a concern for metastatic disease, the workup evaluation should be based on her symptoms. So if the woman has bone pain, she might need a bone scan or perhaps a CAT scan. Some doctors order PET scans. I'm wary of too many of those because of the higher dose of radiation of PET scans, but sometimes that's helpful. Sometimes just blood work can be helpful to evaluate the bone marrow and the liver where cancer may have spread. It really depends on the symptoms. If a woman has unusual headaches or certain problems that could happen in the head, she may need imaging of the head or the brain. But I think the workup and evaluation of a woman after breast cancer should depend on the symptoms. I'm not an expert in nipple-sparing surgery. I would think that a biopsy might be needed if there were a local growth there or some sort of lump in the region or on the skin. That's really all I could suggest there. I would defer to it.
One of the things that we talk a little bit about in the world of prostate cancer is that women have two breasts, men have one prostate, which puts a different logic on screening and prevention and the like. And one of the questions was related to if there is cancer detected in one breast, is the risk of developing a cancer in the other breast increased at all? Should that be a cue to use screening processes in the other breast? And the specific question was related to if, for instance, in the initial lesion detected and treated was HER2 positive breast cancer, let's say, would the cancer, if it were to appear in the other breast, be expected to be HER2 positive, or might it be different? Might it be estrogen receptor positive?
Okay, so that's a good question, and it's an unfortunately common concern as women have lumpectomy or single-sided mastectomy. If a woman has a history of breast cancer, her history of developing another breast cancer is greater, significantly. And so yes, that woman would warrant and should get more screening than the average person, and that the wave screening, sonograms alternating with MRIs and mammograms should be discussed with the oncologist and perhaps the primary care physician. As far as the cancer being different, that can absolutely, and that whenever a person has a recurrence of cancer or a new cancer, it needs to be biopsied, and I would recommend full molecular evaluation of any recurrent or new tumor.
Well, sounds perfect. So that I think we're ready to examine the results of the second poll question. I think we're actually on perfect time, as I can see it, which is, if you've been screened for any of these types of cancer, have you shared the results with your family? And what we see is that 79% of you say you've had. So there's shared decision making not only with a physician, but with a loved one, with someone who is your advocate for health and life as well. Um, so with this, and I'd like to thank very much the folks at the AACR running this webinar. We've been able to stay precisely on time. I think that's miraculous in many ways. And part of it is that it's been so wonderful to engage all of you who participated in this webinar, delivered questions, answered poll questions, and the like. And slides of the presentation that you saw, sometimes we went through them quickly trying to stay on time, they're going to be available in the handout section of the webinar. And we also are providing a Cancer Today story on screening guidelines generally that you can use. And please fill out the webinar survey at the end. The purpose of these webinars is to benefit all of you. And if we can serve you by providing the best possible information on cancer, cancer research, where cancer is now, where cancer care and cancer research is heading in the future, we believe we can empower you to advocate for your own health, advocate for the health of your loved ones, and that's something we'd very much like to help you to do. So please fill out the survey. We'd be delighted to hear what you think and hope to change or improve these webinars based on them. So thank you very much, all of you, Dr. Schaffner and Dr. Hawk and the AACR staff who put this on, and all of you who attended. Thank you.